Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast, your podcast for on-the-go radiology board review. On this episode, I will be discussing extrapulmonary tuberculosis, particularly vascular tuberculosis, as well as tuberculosis involving the gastrointestinal and genital urinary system and musculoskeletal system. I will make a study guide that is free and downloadable, available on my website, www.theradiologyreview.com, that goes over the topics discussed in this episode. This will be presented in a question and answer format, and without further ado, let's go to the first question. What is a Rasmussen aneurysm? Take a moment to consider that. What is a Rasmussen aneurysm? A Rasmussen aneurysm is a pulmonary artery pseudoaneurysm that is secondary to pulmonary tuberculosis. Again, this is a pulmonary artery pseudoaneurysm that is secondary to pulmonary tuberculosis. And that leads us into the next question. Is hemoptysis in general most common from a bronchial artery or pulmonary artery source? And this is a general question that does pertain to tuberculosis, but is also more general for hemoptysis. So, in terms of hemoptysis, is the bleeding most common from a bronchial artery or pulmonary artery source? The answer is that hemoptysis 90% of the time is from a bronchial artery source. On angiography, bronchial artery bleeding may not show a blush of active contrast extravasation as we are accustomed to see elsewhere, such as in the abdomen for gastrointestinal bleeding, but rather, bleeding bronchial artery vessels may simply appear enlarged and tortuous. If a patient has hemoptysis and you perform angiography and see enlarged and tortuous bronchial vessels, that may signify the source of bleeding, even if you do not see active contrast extravasation, and hemoptysis is 90% of the time from a bronchial artery source. Now remember that a Rasmussen aneurysm is a pulmonary artery pseudoaneurysm, so that leads us to the next question. Is hemoptysis from tuberculosis most common from a bronchial or a pulmonary artery source? This is getting a little more challenging, but I think you can do it. The answer is that although you can have Rasmussen pulmonary artery pseudoaneurysms with tuberculosis, hemoptysis in tuberculosis is most common secondary to tuberculosis causing occlusion of pulmonary arterioles, which causes subsequent bronchial arterial hypertrophy that predisposes to bleeding and the bloody cough associated with tuberculosis. So the answer is that the bleeding is technically from bronchial artery hypertrophy, but the cause of the bronchial artery hypertrophy is thought possibly to be related to tuberculosis causing occlusion of the pulmonary arterioles that causes subsequent bronchial arterial hypertrophy, and those bronchial arterial branches that are hypertrophied are prone to bleeding, and thus you have the hemoptysis from tuberculosis. Let's now transition into some questions about gastrointestinal tuberculosis. First, tuberculosis most commonly involves which portion of the small bowel? The answer is that tuberculosis most commonly involves the terminal ileum of the small bowel. Other classic infectious agents that like the terminal ileum, especially on board exams, are Yersinia and Campylobacter. So if you see findings consistent with ileitis of the terminal ileum or terminal ileitis, you can think in terms of infectious agents of tuberculosis, Yersinia, and Campylobacter. I would think of those first on board exams. Tuberculosis of the terminal ileum can also extend into the cecum, and you can see what is called a coned appearance of the cecum, and you can also see evidence of cecal narrowing and ulcer formation. True or false? Peritoneal carcinomatosis is common in extrapulmonary abdominal tuberculosis. Peritoneal carcinomatosis is most common from malignancy, such as ovarian, colon, breast, and gastrointestinal cancers. So if you see peritoneal carcinomatosis, think malignancy first, think ovarian, colon, breast, and GI cancers. However, the differential diagnosis of peritoneal carcinomatosis includes tuberculosis and lymphoma. Remember, both TB and lymphoma are great mimickers of many processes in the body and are nearly on the differential diagnosis of, it seems like, just about everything. If peritoneal carcinomatosis is non-malignant, then TB is a potential leading cause of this appearance, and peritoneal carcinomatosis is certainly something that can be seen with extrapulmonary tuberculosis. Let's ask some genitourinary questions. First, true or false? Tuberculosis of the urinary bladder denotes renal involvement of tuberculosis. So another way to ask this is, if you have tuberculosis of the urinary bladder, what does that tell you about the chances that the kidneys are also involved with tuberculosis? So true or false, tuberculosis of the urinary bladder denotes renal involvement of tuberculosis. This is true. If you have tuberculosis of the urinary bladder, you nearly always have a source from the kidneys. So with urinary system tuberculosis, you always need to evaluate the upper and lower urinary tracts. Signs of bladder involvement of tuberculosis include things like urinary bladder pseudodiverticula, urinary bladder wall thickening, as well as renal findings of tuberculosis. That brings us to the next question. How can you differentiate between renal tuberculosis and nephrocalcinosis? I assume that many of you know that nephrocalcinosis and renal tuberculosis both are causes of renal parenchymal calcifications. So how can you differentiate between these? The answer is that sometimes you cannot differentiate between these, but if you are presented with a single kidney with diffuse parenchymal calcifications, think renal tuberculosis rather than nephrocalcinosis. If you see bilateral diffuse parenchymal calcifications, think nephrocalcinosis first, with tuberculosis on the differential, especially if other findings are also supportive of tuberculosis. So if they show you pulmonary findings of tuberculosis, or they show you calcified lymph nodes in the abdomen, plus bilateral renal calcifications with diffuse parenchymal involvement, you would think tuberculosis. If you see bilateral isolated diffuse parenchymal calcifications of the kidneys, you may think nephrocalcinosis first. And if they show you a single kidney with diffuse parenchymal calcifications and the other kidney looks normal, think renal tuberculosis rather than nephrocalcinosis. Clear as mud? All right, let's move on. Next, what are common imaging manifestations of renal tuberculosis? This is a broad question, but can you think of some common imaging manifestations of renal tuberculosis? In general, there are two main categories of how renal tuberculosis can present. The first is a pyelonephritis-like appearance, and the second is a tumor-like appearance. Pyelonephritis-like appearance would look like other types of pyelonephritis where you have diffuse renal involvement. The tumor-like appearance may present with one or multiple renal masses. Renal calcifications, tuberculomas around the renal collecting system, which cause infundibular stenosis, and renal papillary necrosis are common with renal tuberculosis. More advanced renal TB may show ureteral stenosis and stricturing in both the upper and lower tracts with hydronephrosis, which in a late stage can cause autonephrectomy. We do not want our patients to have autonephrectomy, so that is an unfortunate end-stage complication of renal TB that can result from severe ureteral stricturing and stenosis, causing hydronephrosis and loss of the renal parenchyma and eventually autonephrectomy. Advanced renal TB can also present with diffuse renal amorphous calcification, which is termed the putty kidney, and this pertains to the question I asked previously on diffuse renal calcifications in tuberculosis versus nephrocalcinosis. Putty kidney is a buzzword for renal tuberculosis. I think the sign was initially a plain film sign, and you are now aware of this. Clinical symptoms of renal tuberculosis include hematuria and flank pain, and obviously you may have symptoms elsewhere, such as in the lungs, from the likely coexisting pulmonary tuberculosis. Next, what are some common complications of pelvic inflammatory disease from tuberculosis? So I'm telling you that TB can cause pelvic inflammatory disease. What are some common complications of this? Well, first of all, you should think of infertility. You should also think of tubo-ovarian abscess, and you should think of tuberculosis peritonitis. I think those are three common potential complications from pelvic inflammatory disease from tuberculosis. Again, infertility, TB peritonitis, and tubo-ovarian abscess. On imaging with PID from tuberculosis, look for fallopian tube stricturing on a hysterosalpingogram. Also, you can see filling defects within the endometrial cavity from tuberculosis involvement, and you may see calcified lymph nodes in the pelvis and adnexal regions. That can clue you into the potential of tuberculosis. Next question. What is the most common site of extrapulmonary tuberculosis? This is a really broad question, but take a guess. What is the most common site of extrapulmonary TB? The answer is that extrapulmonary TB most commonly involves the abdomen, generally within the peritoneum, and peritoneal involvement of tuberculosis is actually, I've read, the most common site of TB involvement in the abdomen. On imaging, look for peritoneal nodularity and carcinomatosis, as we previously discussed. Also look for ascites and lymphadenopathy. Peritoneal tuberculosis can result in omental caking. If you don't know what that looks like, you need to look it up. Omental caking, a very thickened omentum. Omental TB can also cause fibrous adhesions, which could cause things like bowel obstruction or stricturing of the ureters, and you can also see loculated ascites. In terms of extrapulmonary TB, you need to be aware of the potential for TB involvement of the peritoneum, causing diffuse imaging manifestations to include omental caking, peritoneal carcinomatosis, adhesions, and ascites, which may be loculated. Next, true or false? Skeletal tuberculosis is always secondary to pulmonary tuberculosis. The answer is true. Isolated skeletal tuberculosis essentially does not happen, at least for board exam purposes. So skeletal tuberculosis always tells you that the patient has pulmonary tuberculosis. Next, what is the top musculoskeletal site of tuberculosis? The answer is the spine, okay? The spine is the top musculoskeletal site of tuberculosis. Next, what is POTT disease? That's P-O-T-T, POTT disease. POTT disease is tuberculous osteomyelitis discitis of the spine, which is also termed tuberculous spondylitis. Most commonly, pot disease involves the lower thoracic and upper lumbar spine. And patients with pot disease present with back pain, leg weakness, paraplegia, and kyphosis of the thoracolumbar spine. TB involvement is mostly anterior within the spine, and the TB infection can track beneath the anterior longitudinal ligament. So that means we need to look for anterior predominant paravertebral inflammation, anterior predominant paraspinous abscesses, and anterior vertebral body irregularity. More advanced disease can present with ivory vertebrae or an ivory vertebral body, and what that means is an extremely dense vertebral body that is otherwise normal, meaning it has normal height, normal size, but you have a solitary, extremely dense vertebral body. One thing that can cause that is tuberculosis. Additionally, you can develop the Gibbous Deformity, which is that thoracolumbar kyphosis. Okay, Gibbous Deformity equals thoracolumbar kyphosis. And you can also have Vertebra Plana, which is a severe compression fracture of a vertebral body that results in a pancake-like flattened vertebral body appearance. Next, what are common differential considerations for Vertebra Plana? Again, Vertebra Plana is that pancake vertebrae, that very thin vertebrae from a very advanced compression fracture. What are differential considerations for Vertebra Plana? For board exams, think of Langerhans cell histiocytosis, especially in a child. If they show you a radiograph or CT of a pediatric patient who has Vertebra Plana, you should consider Langerhans cell histiocytosis. You should also consider things like osteogenesis imperfecta. And in kids and adults, you can think of leukemia. In adults, you can think of myeloma, metastatic disease, trauma, and tuberculosis as well. Next, after the spine, what is the second most common site of musculoskeletal tuberculosis? Now, there may be some differing opinions here, but what I've seen is the hip. So I would at least remember that the spine is the number one site of musculoskeletal tuberculosis. The hip may be the second most common site. The knee is also a common site. Basically, your large weight-bearing joints are common sites for TB involvement. And that leads us to the final question for this episode. Is TB arthropathy most commonly monoarticular or polyarticular? You have a 50-50 chance to get this one right, and the answer is that monoarticular involvement is most common with TB arthropathy. Note that TB arthropathy presents similar to other inflammatory or infectious arthropathies and can present with periarticular osteopenia, peripheral osseous erosions, and progressive joint space narrowing. MSK involvement of TB is always secondary to pulmonary involvement of TB. So if they show you a joint that shows periarticular osteopenia, peripheral osseous erosions, and progressive joint space narrowing, and also show you evidence of pulmonary findings consistent with tuberculosis, you need to have TB arthropathy high on your differential considerations for that question. That's all for now. I hope these episodes are helpful for you. If you haven't yet, please share this podcast with a friend, a co-resident, or other interested radiology learners. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams. Prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.